Hi friends, welcome to Sahakari Race Plus. This is Dr. Anugraha here. As we all are looking forward for the upcoming Casualty Medical Officer exam, we are here to help you walk through it with confidence. In our session, I've taken a few important topics from medicine. Let's start with GIT. So, let's start right away. What do you mean by malabsorption? Before I tell you what that is, I'm sure you guys know that. Let's read a question. A 35-year-old female patient on oral contraceptive pills complains of intermittent abdominal pain, diarrhea for the last few months. Colonoscopy reveals rectal sparing. See, this is important. And gross appearance of the ileum is shown. Okay, this is something called as cobblestone appearance. We'll talk about all these. Which of the following is a specific feature related to this patient's underlying condition? We'll come back to this question. Alright. Now, what is a malabsorption? Malabsorption means if your gut is not able to absorb properly the carbs you're eating, the proteins you're eating, the vitamins, the minerals, the water. So, if your body is not able to absorb it properly, that is called as malabsorption. The question here is, what is the hallmark feature? Oralku malabsorption undengil, what is the hallmark feature that you will see in him or her? The answer is steatorrhea. This is a PYQ. Now tell me, what is steatorrhea? Steatorrhea means fat in the stool. Okay, that is in simple way if I have to explain. Now, the definition of steatorrhea is bulky, frothy, foul-smelling stool. So, I told you malabsorption means when proteins, carbs, vitamins, minerals, all of these, and of course fat, all of these are not getting absorbed properly. Now, my question is, why the first feature or the hallmark feature we take it as fat in stool? That is because these proteins, carbs, they are water soluble, and compared to fat, it is more easy for these products, protein island, carbs island, for them to get absorbed. It is easier compared to fat. But fat absorb I require bile salts, I require pancreatic enzymes. Okay, so to absorb fat, the job is more. Okay, if there is malabsorption in the body, first to come out in the stool is going to be fat. Whipple's disease. Whipple's disease, see, it is an infection of the small intestine by an organism called as Trophirema whipple. So, this is a gram-positive bacteria, Trophirema whipple. See, gram-positive actinomycete. You will learn about all these in micro. See, actino means what, guys? Branching filaments and artha. Branching. Mycete means fungus. So basically it looks like a fungus. That is why the name actinomycete. Anyways, Whipple's disease is caused by what? Trophirema whipple. Now, what happens? Let's go to the pathogenesis of Whipple's disease. First I'll read it, then I'll explain it. The patient gets infected with this bacteria. Okay? And there is this defective macrophage degradation, accumulation of pus-positive foamy macrophages in the lamina propria, malabsorption, and systemic spread. I'll tell you what that means. In our body, if any infection, any bacteria enters, you know what? Let us say this is the bacteria. Our body, normal person, our body immune system, it will send its fighters called as macrophages. What is it? Macrophages to destroy the foreign body, the bacteria or virus. So the immune system fighters are macrophages. They will come and eat it up. Okay. But in Whipple's disease, because of defective immune system, what happens is, see, this infection has reached the intestine, but if an altered immune system karanam, okay, macrophages, let me draw a macrophage. The macrophage will come and engulf the bacteria. Till here it is okay. But ideally macrophage enda cheyandadu ee bacteria ne കൊന്നു കളയണം, destroy ചെയ്യണം. പക്ഷേ in people who have got defective immune system, what happens? The macrophages are defective. They cannot kill the bacteria completely. Okay, so what happens? This bacteria, okay, will keep on multiplying inside the macrophage. Okay, so this particular appearance of the macrophage where, bacteria, the remnants, debris, this appearance gives the macrophages a foamy appearance. Foamy ennu vechal vacuolated. Okay, because of the multiplication of bacteria inside the macrophages. Ideally, macrophages endu cheyanayirunnu ee bacteria ne konnu kalayanam. Pakshe ivide ee Whipple's disease il avarku altered immune system aanu, and the macrophages ande agathe endu vettum, this bacteria, they cannot completely kill the bacteria, so the bacteria will multiply and it makes the macrophages foamy in appearance, means vacuolated, like ഒരു സ്പോഞ്ച്, കുറേ ഹോൾസ് ഉള്ള സ്പോഞ്ച് ഇല്ലേ, അതേപോലെ ഇരിക്കും നിങ്ങൾ ഈ മാക്രോഫാജസിനെ കാണാനായിട്ട്. Okay, so these macrophages, they will get accumulated in a layer of the small intestine called as lamina propria. It is one layer of the intestine. So, these macrophages evideyana chenna accumulate avunathu in the lamina propria of the intestine. And this leads to, once the intestinal walls are damaged, once a layer, ee layer nathu ee macrophages inde piling up undavum, what happens? That gets damaged and intestine will not be able to absorb well. This leads to malabsorption. Also, the macrophages, what it does? Avadatana nikkathilla. It will spread. These macrophages will spread the infection to other parts of the body. Okay, it can spread the bacteria to the heart, to the joints, to the neural system. So there is a systemic spread of the infection also. So this is a pathogenesis, basically defective macrophages allengil defective immune system karanam undavunna problem aanu. Okay, now what is the treatment of Whipple's disease? See, anyways, it is a bacterial infection, so you start him on antibiotics. Initial phase under, maintenance phase under. Initial 2 to 4 weeks we give ceftriaxone or penicillin G, and maintenance phase for 1 year we give trimethoprim, sulfamethoxazole. All right. See, one question. I told you this is a bacterial infection, right? So, what we do? The investigation is we take the biopsy from the small intestine when viewed under the microscope, okay? And in the lamina propria, you get to see macrophages. These macrophages in the agatindandavum, these macrophages will look foamy, vacuolated, okay? So if you see foamy, vacuolated macrophages in the lamina propria of the intestine, you must think about Whipple's disease. Now my question is, say it is a bacterial infection. Ningalku blood test cheyan pattumo? Illa, blood test cheyda most probably it won't, you won't be able to identify the disease, because the bacteria, it stays where? It stays inside the macrophages in the lamina propria of the intestine. But ningal blood test cheyda, you may not be able to identify it. Okay. In a stool culture, yes, sometimes, yes, bacteria may come out, pakshe, to cultivate this bacteria, it is T. Whipple, that is difficult. So the best investigation is you take the biopsy, okay? Intestinal biopsy. And you look for foamy macrophages in the lamina propria. All right, let's move to the next topic. Oh, we have a code to remember Whipple's disease. Pass me the foamy whipped cream in a can. Very simple. See, I didn't mention that. See, this is a macrophage. Idante agathe bacteria unda, okay? And this bacteria has got what, the bacteria will multiply cheyondirikkana. But this bacteria nagathe, it has got a component called as glycoprotein. Endana? Glycoprotein. And if I want to view glycoprotein under the microscope, I use a stain called as PAS. What is it? Periodic acid shift stain. Okay, so if you want to see the bacteria in the macrophages, in the lamina propria, you take the biopsy from the small intestine, and which stain will you use? You use PAS stain. All right, now let's come to the code of Whipple's disease. PAS is for PAS positive, okay? Foamy That is foamy macrophages you will see. Microscope you will foamy macrophages. Whipple's disease. And CAN, it stands for, C stands for CVS, A stands for arthritis, and N stands for neural involvement. This bacteria, it has a systemic spread. Intestine it will spread to other parts. So from CAN you will remember C stands for the bacteria can affect your circulatory system. Okay, CVS, A, bacteria can go to the arthritis, N, neural tissues and cause damages there too. So this much is clear? Okay, let's do the question. Which staining technique is diagnostic of Whipple's disease, guys? We just learned it now. See how simple it is? Pass stain. Okay. And what does pass stain show? It shows foamy macrophages. Now we move on to another important topic, that is celiac disease. Celiac disease is also called as gluten sensitive enteropathy. So look here, see, in our intestine, you guys know that we have got villi, right? We have got villi. And in celiac disease, the intestine looks something like this. We'll talk about it. What is the definition of celiac disease? First point, it is a immune-related disease, okay, where the small intestine is involved and people who eat gluten, they are affected. First point, it is an immune-mediated problem. Okay? This problem in those people, they are very reactive or sensitive towards gluten. Okay. Now, etiology is, if that person, our immunity problem, patient, if he eats any food item that contains gluten, like what food items am I talking about? What food items am I talking about? Yes, I'm talking about bro, that is barley, rye, oats, wheat. These food items we have gluten. Gluten, they cannot digest it well. In fact, they cannot digest it well, it can cause problem to them. So, that's celiac disease. So, what is exactly the problem here? See, genetic problem. In one word, if somebody asks you, what is the problem in celiac disease? Okay. You will just say this. It is because of HLA DQ2 or DQ8 polymorphism. Okay. This is very important. It has come in most of your papers, your NEET PG, FMG, INI-CT, and of course the coming exams as well. Casualty Medical Officer exams. Why celiac disease occur? What is the genetic predisposition? It's because of HLA DQ2 or DQ8 polymorphism. And artha See, HLA stands for human leukocyte antigen. Okay, so when this HLA gene, okay, when it gets a special variety, a DQ2 polymorphism means different version of a gene, or a special version of a gene. Okay, that's polymorphism. So HLA gene in there, versions are DQ2 and DQ8. We get to see celiac disease. See, actually in our general population, about 30% of the people our polymorphism ഉണ്ട് HLA DQ2 DQ8 ഉണ്ട് പക്ഷേ ഈ polymorphism ഉള്ള എല്ലാരിലും നമ്മൾ ഈ celiac disease കാണത്തില്ല. Only about 4%, ഈ 30% ഇന്ന് about 4% ആൾക്കാരിൽ മാത്രമേ നമ്മൾ celiac disease കാണുള്ളൂ. Okay, so we'll talk about the pathology. It's very interesting. Celiac disease is very interesting. So this much you understood. ഒരു immune related problem ആണ്. Intestine gluten അവർക്ക് ശരിക്കും absorb ചെയ്യാൻ പറ്റുന്നില്ല. അത് മാത്രമല്ല, intestine is also damaged because of intake of gluten. And why it happens? Genetic reason endana because of HLA DQ2 DQ8 polymorphism. This much understood? Understood. Now let's go to the next. Okay, so these food items such people should avoid. Okay, that is the mainstay of treatment. When we talk about the treatment, we'll say there's nothing else we can do. You just avoid the food that has got gluten, right? And then life becomes easier. So pathogenesis. See, gluten, it is a protein that you find in wheat, barley and rye. Okay, this gluten, I'm drawing gluten here. This gluten has got one component. Okay, so this gluten, okay, inside gluten, it has got a component called as, I'm just drawing it like this. Inside gluten, we have a component called as gliadin. What is it? Gliadin. Now what happens is, when, okay, first we'll read it, then I'll explain. When gliadin enters the small intestine, an enzyme TTG modifies it, and then autoimmune reaction starts. First, let me draw something. You'll understand it better. So this is the intestine. The patient who has his polymorphism has taken gluten. Gluten has entered his small intestine, and you know what happens? This gluten agathe endundu. ഞാൻ ഇവിടെ ഒരു gluten molecule വരയ്ക്കുകയാണ്. അതിന്റെ അകത്ത് it has got gliadin. Okay. Now, ഈ ഒരു genetic variation ഉള്ള ആൾക്കാരിൽ, you know what happens? Small intestine, we have got an enzyme. We have got an enzyme called as small intestine, called as TTG. What is it? Tissue transglutaminase. Now, normally tissue transglutaminase, this enzyme in the joli endan joicha, if there is any breach in the intestinal wall, it patches it up. Okay, it's a good boy. TTG. So intestinal endengil oru tear undengil adine ready aakum. Adana ante normal function. But inganathe aalkarilla who's ഈ genetic problem ഉള്ള ആൾക്കാരിൽ this TTG enzyme, you know what it does? It will go and you know what it will do? ഈ gluten അകത്തുള്ള gliadinൽ ഇത് ആക്ട് ചെയ്യും. It will act on gliadin. And എന്താ ചെയ്യുന്നതെന്ന് അറിയോ? It does something called as deamidation. Deamidation. Okay, I'll tell you what that means. ഈ gliadin അകത്ത്, see, itrem detail I don't think they last, but I believe that you should understand things and learn instead of just mugging up, okay? So it just takes 30 seconds. We'll understand it and go. See, ee gliadin agathe, we have got a molecule called as, okay, this gliadin has got a molecule called as glutamin. An amino acid aanu. Okay? Gliadin agathe endu molecule undu? Amino acid aanu, glutamin undu. Appo ee TTG chennittu, okay? ഈ ഗ്ലൈഡിൻ അകത്തെ ഗ്ലൂട്ടാമിനെ ഗ്ലൂട്ടാമിക് ആസിഡ് ആയിട്ട് കൺവേർട്ട് ചെയ്യും. ഇത്രയും മനസ്സിലായോ? ഇതിനെയാണ് ഡീഅമിഡേഷൻ എന്ന് പറയാം. ഓക്കെ, സോ ഇറ്റ് ഇസ് നോട്ട് നോർമൽ. ഇറ്റ് ഡസൻറ്റ് ഹാപ്പൻ ഇൻ നോർമൽ പീപ്പിൾ. only people who have that genetic problem, this step happens. Now when this deamidation occurs, ഇവരുടെ immune system thinks that this modified version of gliadin അതൊരു ഫോറിൻ ബോഡിയാണ്, അതെൻ്റെ ബോഡീനെ ആക്രമിക്കാൻ വരികയാണ് എന്നാണ് ഇങ്ങനത്തെ ആൾക്കാരുടെ ഇമ്മ്യൂൺ സിസ്റ്റം ചിന്തിക്കുന്നത്. വൺസ് അഗൈൻ, ഡീഅമിഡേഷൻ നടക്കുമ്പം ഈ TTG എൻസൈം എന്ത് ചെയ്യുന്നു? നമ്മുടെ ഗ്ലൂട്ടൻ്റെ അകത്തെ ഗ്ലയാഡിനിൽ ചെന്ന് ആക്ട് ചെയ്യുന്നു. ഗ്ലയാഡിനകത്ത് എന്തുണ്ട്? ഗ്ലൂട്ടാമിൻ എന്ന് പറഞ്ഞ അമിനോ ആസിഡ് ഉണ്ട്. അതിനെ ഗ്ലൂട്ടാമിക് ആസിഡ് ആയിട്ട് കൺവേർട്ട് ചെയ്യുന്നു. ഓക്കെ, ഇതിനാണ് ഡീഅമിഡേഷൻ എന്ന് പറയുന്നത്. അപ്പോൾ ഇങ്ങനെ ഒരു കൺവേർഷൻ നടക്കുമ്പം അയാളുടെ ഇമ്മ്യൂൺ സിസ്റ്റം തിങ്സ് ദാറ്റ് ഓക്കെ, ഈ പാർട്ടിക്കിൾ, ദിസ് ഗ്ലൂട്ടൻ പാർട്ടിക്കിൾ ഇതൊരു ഫോറിൻ ബോഡിയാണ്, അല്ലെങ്കിൽ എൻ്റെ ബോഡീനെ ആക്രമിക്കാൻ വന്നാണ്, ഐ ഷുഡ് കിൽ ഇറ്റ് എന്ന് അയാളുടെ ഇമ്മ്യൂൺ സിസ്റ്റം ചിന്തിക്കും. Okay, and you know what the immune system does? It will send its immune cells, T cells, immune cells, and tries to destroy the gluten particle in the intestine. Appo ee oru process la, when the gluten is trying to be destroyed by the patient's immune cells, ee oru process la it can lead to inflammation and damage to the intestinal mucosa. Understood? Yeah, that's what I've written here. Damage to the intestine. T cells and antibodies, they come and attack the intestinal lining. Gluten എവിടെയാണോ ഉള്ളത് അവിടെ ചെന്ന് gluten ഇവർ ഇമ്മ്യൂൺ സിസ്റ്റം വിചാരിക്കുന്നത് എന്താ? gluten ഒരു ഫോറിൻ ബോഡിയാണ്, എൻ്റെ ബോഡിക്ക് നല്ലതല്ല, അതിനെ ഞാൻ കൊല്ലട്ടെ എന്ന് പറഞ്ഞിട്ട് T cells will come and kill it. Okay, so in the process, the small intestine gets inflamed. And over time, okay, when the small intestine, when it gets inflamed, it can lead to what? Villus atrophy. ഇതാണ് normal villi, right? But because of the ongoing inflammation, there could be what? Villus atrophy happening. But villus atrophy നടക്കുവാണെങ്കിൽ absorption ശരിക്കും നടക്കുമോ? ഇല്ല, absorptionും ഇവിടെ damaged ആയിരിക്കും. Okay, that's what is written here. when there is villus atrophy, less surface area, because see here, ഇവിടുത്തെ surface area നെക്കാട്ടി കുറവാണ് ഇവിടെ because of villus. ഇത് normal villi. Inflammation കാരണം in celiac disease what happens? The villi get damaged, right? And here ഇവിടെ surface area കുറയുന്നു. So poor absorption of nutrients and it leads to malabsorption. Okay, now this is important. Antibodies formed in celiac disease. Now, these 3 antibodies, that's all they ask, you should know. Anti-TTG antibodies, anti-gliadin antibodies, anti-endomycin antibodies. See, let's understand why these antibodies are formed. Okay, so I have intestine varichitunda, and this is the gluten inside the intestine. Okay, from intestine length under they have got intestine we have got tissue transglutaminase എന്ന് പറഞ്ഞൊരു enzyme ഉണ്ട്. ഈ enzyme എന്ത് ചെയ്യുന്നു? It will come and act on gluten. ഇത്രയും വരെ നമ്മൾ പഠിച്ചു. Okay. So, see, as immune system, you know, I told you it produces antibodies first against the gliadin. ഈ gluten അകത്ത് എന്തുണ്ട്? Gliadin ഉണ്ട്. അപ്പോൾ gliadinനെയാണ് actually നമ്മുടെ ഇമ്മ്യൂൺ സിസ്റ്റം ഓക്കെ അത് ടെററാണ്, ഇറ്റ്സ് എ ബാഡ് പേഴ്സൺ, സോ ഐ ഹാവ് ടു കിൽ ഇറ്റ് എന്ന് പറഞ്ഞിട്ട് ഗ്ലൈഡിനെതിരെ ആന്റിബോഡീസ് ഫോം ചെയ്യുന്നു. സോ അതാണ് ഞാൻ ഇവിടെ എഴുതിയിരിക്കുന്നത് ആന്റി ഗ്ലൈഡിൻ ആന്റിബോഡീസ്. ഓക്കെ, ദ പേഷ്യൻസ് ബോഡി ഓൾസോ പ്രൊഡ്യൂസസ് ആന്റി TTG ആന്റിബോഡീസ്. കാരണം സി ഈ ഒരു അറ്റാക്ക് നടക്കുന്നില്ലേ, സി ദി TTG എൻസൈം വിൽ അറ്റാച്ച് വിത്ത് ഗ്ലൂട്ടൻ. അപ്പോൾ ഒരു കോംപ്ലക്സ് ഫോം ചെയ്യാണ്. ഓക്കെ, അപ്പം പേഷ്യൻ്റെ ബോഡി എന്താ ചിന്തിക്കണേന്ന് അറിയോ? ഓക്കെ, ഈ ഫോറിൻ പാർട്ടിക്കിളിൻ്റെ ഫ്രണ്ടാണ് TTG. അപ്പോൾ TTGയും സ്വന്തം ബോഡിക്ക് ഹാംഫുൾ ആണ്. സോ ലെറ്റ് മീ പ്രൊഡ്യൂസ് ആൻറ്റിബോഡീസ് അഗേൻസ്റ്റ് TTG ആസ് വെൽ. That is what the patient's immune system thinks. So his body starts producing anti-TTG antibodies. മനസ്സിലായോ? Okay. Now, anti-endomysial antibodies. See, endomysium അർത്ഥം എന്താ? What do you mean by endomysium? നമ്മുടെ skeletal muscle യുനോ ഈ സ്കെലറ്റൽ മസിൽ ഫൈബേഴ്സിന് ചുറ്റിനും ഞാനൊരു സ്കെലറ്റൽ മസിൽ ഫൈബർ വരയ്ക്കുകയാണ്. അതിന് ചുറ്റിനും ഓരോ സ്കെലറ്റൽ മസിൽ ഫൈബറിന് ചുറ്റിനും they have got this connective tissue sheath called as endomysium. What is it? Called as endomysium. Now, see, നമ്മുടെ ഇൻറ്റസ്റ്റൈനി മാത്രമല്ല ഈ ടിഷ്യൂ ട്രാൻസ്ഗ്ലൂട്ടാമിനേസ് എൻസൈം ഉള്ളത്. നമ്മുടെ ബോഡിയുടെ പല ഭാഗത്ത് ഈ ഒരു എൻസൈം പ്രസൻ്റ് ആണ്. സോ അതിൽ ഒരു ഭാഗമാണ് എൻഡോമൈസിയം. ലൈക്ക് സ്കെലറ്റൽ മസിൽ ഫൈബേഴ്സിൻ്റെ ചുറ്റുമുള്ള ഷീത്തിനെയാണ് നമ്മൾ എൻഡോമൈസിയം എന്ന് പറയുക. സോ ഈ എൻഡോമൈസിയത്തിലും എന്തുണ്ട്? ദേ ഓൾസോ ഹാവ് ദി എൻസൈം TTG. ഓക്കെ, അപ്പോൾ സീലിയാക് പേഷ്യൻറ്റിൻ്റെ ബോഡിയിൽ ഇറ്റ് തിങ്സ് ദാറ്റ് ഓക്കെ ഗ്ലൈഡിൻ ഒരു ഹാംഫുൾ സബ്സ്റ്റൻസ് ആണ്, അപ്പോൾ അതിനെതിരെ ആൻറ്റിബോഡി പ്രൊഡ്യൂസ് ചെയ്തു. TTG, ഇപ്പോൾ ഗ്ലൈഡിൻ്റെ തൊട്ടടുത്തല്ലേ TTG ഇരിക്കുന്നത്, ഒരു കോംപ്ലക്സ് ആയിട്ട് ഫോം ചെയ്യാണ്. അപ്പോൾ ബോഡി എന്ത് വിചാരിച്ചു? ഓക്കെ, TTG ഗ്ലൈഡിൻ്റെ ഫ്രണ്ടാണ്, സോ ഞാൻ TTGക്കെതിരെ ആൻറ്റിബോഡി പ്രൊഡ്യൂസ് ചെയ്യട്ടെ എന്ന് വിചാരിച്ചിട്ട് ഇറ്റ് പ്രൊഡ്യൂസ്ഡ് anti-TTG ആൻറ്റിബോഡീസ് ആൻഡ് endomysial ആൻറ്റിബോഡീസ്. See, I told you endomysium produces what? TTG. So, our body thinks that our body എന്താ വിചാരിച്ച് വെച്ചേക്കുന്നത്? TTG ഹാംഫുൾ ആണെന്നാണ് അല്ലേ? അപ്പോൾ TTGനെ പ്രൊഡ്യൂസ് ചെയ്യുന്ന എൻഡോമൈസിയത്തിനെതിരെയും ബോഡി എന്ത് പ്രൊഡ്യൂസ് ചെയ്യും? ആൻറ്റിബോഡീസ് പ്രൊഡ്യൂസ് ചെയ്യും. മനസ്സിലായോ? അതുകൊണ്ടാണ് anti-endomysial antibodies are seen. Got it? No problem. Don't go so much deep into it. I just wanted you to understand. That's why. Just today before the exam, all you have to revise is these 3 antibodies. Okay, anti-TTG antibodies, anti-gliadin antibodies, and anti-endomysial antibodies. അപ്പോൾ ഇതിനകത്ത് മോസ്റ്റ് സെൻസിറ്റീവ് അത് ചോദിച്ചിട്ടുണ്ട്. anti-TTG antibodies ആണ് മോസ്റ്റ് സെൻസിറ്റീവ്. മോസ്റ്റ് സ്പെസിഫിക് ഏത് ആൻറ്റിബോഡിയാണെന്ന് ചോദിച്ചാൽ anti-endomysial antibody. Alright guys, ബേസിക്കലി anti-TTG antibody ഒരു സ്ക്രീനിങ് ടെസ്റ്റും anti-endomysial antibody ഒരു കൺഫർമേറ്ററി ടെസ്റ്റുമാണ്. Oh, there is another important thing. What you see here, ഇതെന്താ ഞാൻ ഈ പിക്ചറിൽ കാണിച്ചേക്കുന്നത്? In celiac disease, skin manifestations ഉണ്ടാവാം. That is dermatitis herpetiformis എന്ന് പറയും. Okay, this has come in lot of papers. In celiac disease, there is going to be a cutaneous manifestation, and that is called as dermatitis herpetiformis. See guys, why does it occur? See, antibodies are formed against tissue transglutaminase. We just learned it. അപ്പോൾ നമ്മുടെ സ്കിന്നിൽ ഞാനിപ്പം ഇവിടെ ഒരു സ്കിൻ, ദിസ് ഇസ് സ്കിൻ. നമ്മുടെ സ്കിന്നിൽ ഇറ്റ് ഹാസ് ഗോട്ട് ഈ ടിഷ്യൂ ട്രാൻസ്ഗ്ലൂട്ടാമിനസിനെ പോലെ കാണാൻ ഒരേപോലെ ഇരിക്കുന്ന വേറൊരു എൻസൈം ഉണ്ട്, കോൾഡ് ആസ് എപ്പിഡെർമൽ ട്രാൻസ്ഗ്ലൂട്ടാമിനേസ്. സ്കിന്നിൽ എന്തുണ്ട്? ടിഷ്യൂ ട്രാൻസ്ഗ്ലൂട്ടാമിനേസിനെ പോലെ കാണാൻ സിമിലർ ആയിട്ടുള്ളൊരു എൻസൈം ഉണ്ട്, ദാറ്റ് ഇസ് എപ്പിഡെർമൽ ട്രാൻസ്ഗ്ലൂട്ടാമിനേസ്. അപ്പോൾ ബോഡി ഹാസ് ഓൾറെഡി പ്രൊഡ്യൂസ്ഡ് ആൻറ്റിബോഡീസ് അഗൈൻസ്റ്റ് TTG. ഓക്കെ, അപ്പോൾ ക്രോസ് റിയാക്ഷൻ ഉണ്ടാവും. കാണാൻ ഒരേപോലെ ഇരിക്കുന്നതുകൊണ്ട് ആൻറ്റിബോഡീസ് വിൽ ഗോ ആൻഡ് അറ്റാക്ക് ദ എപ്പിഡെർമൽ ട്രാൻസ്ഗ്ലൂട്ടാമിനേസ് ഓൺ ദ സ്കിൻ. ആൻഡ് ഈ ഒരു അറ്റാക്ക് കാരണം ദേ ആർ ഗോയിങ് ടു ഹാവ് വാട്ട് ഗൈസ്? They are going to have a cutaneous manifestation in celiac disease called as dermatitis herpetiformis. അപ്പോൾ ഏത് ആൻറ്റിബോഡി ആണ്? you've got different kinds of antibodies, right? അപ്പോൾ ഏത് ആൻറ്റിബോഡി ആണ് ഈ കണ്ടീഷനിൽ ഇൻവോൾവ് ആവുന്നത്? IgA antibodies are produced. Very important. IgA antibodies are produced. Okay, you can see them in dermal papillae of the skin. Okay, so what are the other clinical features for celiac disease? Malabsorption ഉണ്ടാവുന്നു, diarrhea ഉണ്ടാവുന്നു, and gluten first exposed ആവുന്നത് duodenatiലാണ്. Okay, so the first part to be affected is duodenum, and duodenatilana major chunk of iron is getting absorbed. So if duodenum is getting inflamed, is not able to work properly, iron ശരിക്കും absorb ആവാൻ പറ്റോ? ഇല്ല. So that leads to iron deficiency anemia. Okay, and the treatment here is dapsone. Dapsone, see, basically the inflammation കുറയ്ക്കാനായിട്ട് സഹായിക്കും dapsone. But the mainstay of treatment is you stop whatever is causing the problem. You stop eating bro. What is bro? Oh, we have to come to MASH criteria also. Okay, we'll come to the treatment before that. Under diagnosis, what do? You take a duodenal biopsy and see it under the microscope. Okay, so in celiac disease, we have a criteria called as MASH criteria. For MASH criteria, let's see, this is how, the second picture, this is how a celiac disease looks like. This is normal. First picture, normal. You can see the villi, right? You can see the villi. But in celiac disease, see how the picture goes. There is going to be, see, because of immune reaction, inflammation occurring, the villi of the intestine, they get damaged and it leads to atrophy of the villi. So first thing, there is villus atrophy. Can you see? Right? So that is villus atrophy. Okay. Then there is crypt hyperplasia. What do you mean by crypt hyperplasia? See guys, നമ്മുടെ intestine, it has got finger-like projections called as villi. Villi in the edeke, you know what they have? What they have? They've got crypts. From e crypts in okay, basically pits ആണ് crypts എന്ന് പറയും. What I've drawn here, ഇതാണ് crypts. Crypts in എന്തുണ്ടെന്ന് അറിയോ? Stem cells ഉണ്ട്. Okay, stem cells means they have the ability to form new cells. Okay, അപ്പോൾ ക്രിപ്സിന് എന്തുണ്ട്? ഈ മേലെ വരച്ചേക്കുന്നതാണ് വില്ലൈ, താഴെ വരച്ചേക്കുന്നതാണ് ക്രിപ്സ്. ക്രിപ്സിന് എന്തുണ്ട്? സ്റ്റെം സെൽസ് ഉണ്ട്. സ്റ്റെം സെൽസ് what do? They create new cells അല്ലേ? അപ്പോൾ when there is villus atrophy, see, ഇവിടെ വില്ലൈ ഡാമേജ്ഡ് ആണ്. ഓക്കെ, villus atrophy ഉണ്ടാകുന്നു. അപ്പോൾ ഈ ക്രിപ്സിലുള്ള സ്റ്റെം സെൽസ് what does it do? It's thinking, okay, villi is getting damaged, so let me make more cells. Okay, as a compensation, let me make more cells. Okay, so you get to see what? Crypt hyperplasia. You get to see crypt hyperplasia as a compensatory mechanism. Villi atrophy down, but crypt വിചാരിക്കും okay, കുറച്ചും കൂടെ സെൽസിനെ ഞാൻ പ്രൊഡ്യൂസ് ചെയ്യട്ടെ എന്ന് വിചാരിച്ചിട്ട് it will go for crypt hyperplasia. Also, as immune response, okay, because of inflammation, immune response, gluten എതിരെ പ്രവർത്തിക്കാനായിട്ട് lot of T lymphocytes come to the intestine. So അതാണ് ഞാൻ ഇവിടെ എഴുതിയിരിക്കുന്ന intraepithelial lymphocytes can be seen in a lot in number in celiac disease. IEL, intraepithelial lymphocytes. Basically T lymphocytes can be seen a lot in number in that area. Okay, so this is MASH criteria. This is very important. And people with celiac disease, they are at a risk of cancer, which is called as EATL, that is enteropathy associated T-cell lymphoma. This has come, it is a PYQ. Okay, so basically see, ഇവിടെ T cells, ഇങ്ങനത്തെ ആൾക്കാരിൽ T cells, they act a lot to kill the gluten, to destroy the gluten. So over time, ഈ overactivation of T cells can result in abnormal proliferation of T cells, leading to T cell lymphoma. Understood? So what is the treatment, guys? Dietary restrictions, you avoid bro, and rice and maize accepted, and steroids. Okay, celiac disease is due to hypersensitivity to which component of gluten? We just learned it. It is gliadin, right? Which HLA types are strongly associated with celiac disease? HLA യുടെ ഏത് വെറൈറ്റി ആണ് ഈ celiac disease ഉണ്ടാക്കുന്നത്? HLA DQ2, DQ8. Okay, even in our sleep we should be able to say this because it is a very frequent question. Duodenal biopsy in celiac disease shows all except villus atrophy ഉണ്ടോ? ഉണ്ട്. Crypt hyperplasia ഉണ്ടോ? ഉണ്ട്. We just learned it. And there are lymphocytes also, but granuloma formation നമ്മൾ പഠിച്ചോ? Marsh criteria ഇല്ല. It's not there. Okay, so D is the answer. Okay, let's move on to the next topic, that is environmental enteropathy or tropical sprue. See guys, this is also a malabsorption syndrome seen in people who live in tropical regions. Tropical എന്ന് പറഞ്ഞാൽ എന്താ? Near to the equator. അവിടെ hot humid climate ആയിരിക്കും. So a chronic malabsorption seen in people who stay in tropical regions. So which bacteria usually causes problems here? It is E. coli. Chronic infection with E. coli in a person can lead to small intestinal mucosal damage. See, is sprue in artham enda? Sprue actually it means malabsorption syndrome. Okay, that is the meaning of sprue. Now, in this disease, okay, depending upon which part of the intestine is affected, the clinical features will be presented. If duodenum is affected, okay, if there is inflammation in the duodenum, I told you duodenum iron is getting absorbed. So, if duodenum is affected, there is going to be iron deficiency anemia. If ileum is affected, ileumthilana B12, vitamin B12 is getting absorbed, right? So if ileum is affected, vitamin B12 deficiency ഉണ്ടാവുന്നു. B12 ശരിക്കും absorb ആവാൻ പറ്റുന്നില്ല. അപ്പോൾ ഇത് ചോദിച്ചിട്ടുണ്ട് കേട്ടോ. B12, where is it mostly absorbed? In the ileum. So remember B12, one looks like I, okay, and that stands for ileum. Now jejunum, if this disease, if jejunum is more affected, what happens? For jejunathilana folic acid nannayit absorb avuva. If jejunum is affected, folic acid deficiency undavuന്നു. Now you tell me guys, what do you call the anemia if the patient has got B12 deficiency and folic acid deficiency? ഇങ്ങനത്തെ ഒരു anemia നമ്മൾ എന്താ പറയുന്നേ? It's called as megaloblastic anemia. What is it? Megaloblastic anemia. Megaloblast എന്ന് വെച്ചാൽ എന്താ അർത്ഥം? See, it is a precursor of RBC. RBC യുടെ chota forms, like കുട്ടി forms that's seen in the bone marrow. അതിനെയാണ് megaloblast എന്ന് പറയാം. അപ്പോൾ RBCക്ക് പ്രോപ്പർ ആയിട്ട് മെച്യൂർ ചെയ്യണമെങ്കിൽ, for the DNA synthesis to occur in the RBCs, for the proper formation of the nucleus, right, and development of RBCs, they need what? B12 and folic acid. Now if these two are deficient, RBCs they are going to remain what? Round, immature, okay, and so that's called as they are called as megaloblast, and that's it, okay. B12 and folic acid deficiency results in megaloblastic anemia. Deficiencies, depending upon which part of the intestine is affected, there could be folate deficiency, B12 deficiency, okay. Treatment is you give antibiotics, right, and supplements. Now we are moving on to very important topic, two topics actually. Under inflammatory bowel disease, we have got Crohn's disease and ulcerative colitis. ഇത് രണ്ടിന്നും എല്ലാ ക്വസ്റ്റ്യൻ പേപ്പറിലും ചോദ്യങ്ങൾ വരാറുണ്ട്, and very simple, okay. So what do you mean by, okay, it's written here, inflammatory bowel disease. Under that comes Crohn's and ulcerative. Both are multi-system disorders. We'll come back to it. So basically, രണ്ടിലും inflammatory bowel disease basically autoimmune ആണ്. Okay. Here also immunity plays a role, that gets altered, and there is inflammation in the GI tract. അതാണ് inflammatory bowel disease. ഇപ്പോൾ ക്രോൺസിലാണെങ്കിലും അൾസറേറ്റീവിലാണെങ്കിലും the features are not just restricted to the intestine. They can have other systems to get involved. Okay. Arthritis ഉണ്ടാവാം, And remember this point, the most common extra-intestinal manifestation of IBD is arthritis. Important question. The most common extra-intestinal manifestation of inflammatory bowel disease is what, guys? Arthritis. And see, basically the immune system, the immune system starts attacking the bowel, it starts attacking different parts of the body. Okay? So, kannine attack him, it can lead to uveitis, rashes undavam in such people called as pyoderma gangrenosum. Actually, there is a misnomer, these rashes, they are painful rashes. And yeah, so pyoderma, what will we think that, okay, pyoderma means pus, bacterial infection. But adalla. Okay, there is immune reaction aayittu varuna lesion aanu, pyoderma. And there will be necrotic tissue in the lesions as well. That is why the name pyoderma gangrenosum. Now, see, we'll talk in detail about Crohn's and ulcerative, but before that, just one-liners, okay, that they ask you from these topics. Crohn's disease, mostly it is associated with kidney stones. And which kidney stones? Calcium oxalate. Why? Crohn's disease, kidney stones we see. See, we will learn that in Crohn's disease, terminal ileum, that part of the intestine is affected. Avada inflammation undavuന്നു. Okay? But terminal ileathilana, fatty acids are getting absorbed. Okay, I'm telling you the reason why kidney stones are occurring in Crohn's disease. I don't know for further classes if I'll be able to, tell everything in detail, because we really don't need so much of details for the coming, MCQ type of exams. But yeah, anyways, we'll just learn it this way. Okay. See, it makes learning very wonderful, right? We feel to learn. If you understand things, we feel to learn. At some point we'll forget, and we're dealing with human life, so I think this is a better way to learn. So Crohn's disease, there's kidney stones. Look here, very simple. Crohn's disease, terminal ileum is affected. Okay, terminal ileathilana fatty acids are absorbed. Okay. Usually, calcium, okay? Calcium usually pairs with oxalate crystals, okay? And then it passes out through the stools. Normal person oxalate crystals formed in the body, they combine with calcium, okay? And it's passed through the stools. But Crohn's disease, what happens, this calcium, okay? Calcium falls in love with fatty acid. Terminal ileathil fatty acid sherikku absorb avan pattilla. So fatty acid is free, yes, single. So what does calcium do? It will go and get attached with the fatty acid. Okay, so leaving the oxalate crystals alone. Okay, now this alone aayittulla, okay, separated aayittulla oxalate crystals endu cheyyunnu, these oxalate crystals will get absorbed into the bloodstream. Intestine in the bloodstream absorbed down, and then it will go towards the kidneys. Kidney lolla calcium ayittu combine cheyidittu it will try to pass out through the urine. So ee process okay, calcium oxalate crystals kidney il adiyanayittu chance koodudalana. Okay, so yeah, that's why in Crohn's disease, what do you see, guys? Kidney stones are seen, calcium oxalate stones are seen. And ulcerative colitis, this is important. Ulcerative colitis, it is commonly associated with primary sclerosing cholangitis, PSC. This is like very, very important. Basically, it is a dilatation of the bile ducts, that is primary sclerosing cholangitis. So they'll ask you in the question, which pathology? Is it Crohn's or ulcerative colitis? Where you see primary sclerosing cholangitis, the answer is in ulcerative colitis, that is associated with PSC. Now, this disease, see, I told you immune prashna. Antibodies are formed against one's own body. So they ask you, both diseases, which antibodies are formed? This is important. P and K antibodies. What is it? P, perinuclear, anti, neutrophil, cytoplasmic antibodies. Very important. See, before we used to think that P and K positivity was only seen in ulcerative colitis. But new studies show that P and K positivity is seen in both Crohn's as well as ulcerative colitis. Okay, now let's start with Crohn's disease. Okay guys, so what is Crohn's disease? It is an IBD. this here, the inflammation can occur in any part of the GI tract from mouth to anus. But most commonly it affects which part? Important. Terminal ileum. Yeah, so it affects which part, guys? Terminal ileum, and it has got some features, so we'll talk about it. In Crohn's disease, first thing, it is associated with an antibody called as ASCA antibody. Okay, so what? See, ASCA antibody, the full form is anti-Saccharomyces cerevisiae antibody. This is a yeast form. Normally, we don't produce antibodies against it once it enters the body. But people whose immune system is altered, they will produce antibodies against this Saccharomyces cerevisiae. Okay. So, if you are having doubt that the patient is having Crohn's, which antibody will you check? ASCA antibody. Important. We check Crohn's law, ulcerative law. It is in Crohn's we check for ASCA antibodies. Now, in Crohn's disease, we get to see something called as skip lesions. Can you see? This is Crohn's, okay, the intestine. You can see lesion here, lesion here, lesion here. But there are normal areas in between. So, skip lesions means there are areas of inflammation, there are areas of pathology, but there are normal areas in between as well. So, that's why skip lesion. See, here is a lesion, it has skipped certain part. Here is normal. Again, the lesion has come. Again, inflammation has come. So, that is why we say that skip lesions are present in Crohn's. Now, which part is most commonly affected here, guys? Ileum. Ileum is most commonly affected. This has also come. So, all of these points in this slide, they are PYQs. Ileum is most commonly affected. Skip lesions. You understood what is skip lesions, right? Yeah, it's a continuous involvement. Normal, you can see the area of inflammation here. Then you can see normal areas. Again, areas of inflammation. So, it just skips some parts. Okay. Now, in Crohn's, rectum is spared, okay, and there is transmural involvement. What do you mean by transmural involvement, guys? Transmural means it involves all the layers of the intestine. Oh, intestine, it has got mucosa, submucosa, muscularis propria, then it has got serosa. So, all the layers of the intestine, there is going to be the autoimmune changes, and that is called as transmural involvement. See, if I am drawing this is intestine, okay, let's say this is intestine. Okay. When all the layers are inflamed, okay, the pathogenesis happens in all the layers. It can lead to what? It can lead to ulcers, it can lead to fistulas, fissures. So, yeah. Next, that's it. Next, we move on to string sign. What do you mean by string sign? In the intestine, okay, there is going to be, as a response to all these inflammation, fibrotic tissue accumulation in the intestine. Okay. Now, if fibrotic tissue accumulated, what happens to the lumen of the intestine? Yeah, it becomes narrowed. So, this narrow lumen of the intestine, see, here intestine is fine, right? But see, here it is looking like a string, right? It is looking like a string. Why? Because of all the inflammation, what happens? There is going to be fibrotic tissue. Inflammation and down, fibrotic tissue deposition and down the intestine, and over time it narrows the space of the intestine and it makes the intestine like a string. So that is what you see, a string sign. Another thing, okay, aphthous ulcers. In Crohn's disease, the patient is going to have aphthous ulcers, okay, small ulcers, and then the aphthous ulcers can merge to form something like a snake called as serpentine ulcers. So you get in Crohn's disease, you get to see aphthous ulcers, and then sometimes over time, what do? They will merge to form serpentine ulcers. Now, this picture, okay, both these pictures, they come very frequently. See, Crohn's is like very important topic, and ulcerative also, ulcerative colitis. Now, what you see here, നിങ്ങൾ ഈ പിക്ചറിൽ കാണുന്നതാണ് കോബിൾ സ്റ്റോൺ. വാട്ട് ഇസ് ഇറ്റ്? യു കാൻ സീ മീ. നിങ്ങൾ ഈ പിക്ചറിൽ കാണുന്നതാണ് കോബിൾ സ്റ്റോൺ. ഓക്കെ, സോ ദി ഇൻറ്റസ്റ്റൈൻ വിൽ ഹാവ് എ cobblestone appearance in Crohn's disease. See, this is cobblestone and this is a cobblestone appearance of the intestine. Why? Because there are going to be ulcers and edematous mucosa. So it gives a picture of cobblestone. You don't forget. Also, look at this picture here. This is an intestine and you can see fat. Right? Fat is creeping over the intestine. So creeping fat is seen in Crohn's disease. Why? Why do we see creeping fat? See, when I told you intestine ella layers um inflammation undergo cheyana, okay, immune response undagana ella layers ilum intestine inde. Appo to stop the further spread of inflammation from the intestine, mesenteryile fat vannittu evidekkana inflammation avade adine aa intestine cover cheyan nokkum in order to stop the spread of inflammation. So that is why you can see creeping fat. Creeping fat is seen in Crohn's disease. Cobblestone appearance of the intestine, it is seen in Crohn's disease. Oh, then another important thing, when you see this disease under the microscopy, what you get to see is non-caseating granuloma. Okay, so see, granuloma endana, see, this is what you see. What is granuloma, guys? Granuloma means is a collection of immune cells, macrophages, epithelial cells, and they form a nodule. Adineyana granuloma ennu paraya. Non-caseating means if this granuloma does not have, if this granuloma does not have a central area of necrosis, then this is called as non-caseating granuloma. ഈ ഗ്രാനുലോമയുടെ നടുക്ക് if there is a central area of necrosis, we call it as caseating granuloma. പക്ഷേ ക്രോൺസിനകത്ത് നമ്മൾ എന്താ കാണുന്നത്? This picture has come before, PYQ ആണ്. It is a non-caseating granuloma. Okay. What is the treatment? Yeah, we give steroids, we give antibiotics to suppress any superadded infection, and anti-TNF alpha drugs like infliximab. Now, there is something called as metastatic Crohn's disease. See, this is not cancer. Okay, metastatic Crohn's disease no arnja adu cancer alla. When granulomas, they move towards, when they can be seen on the skin surface. But intestine matramalla, intestine la granuloma undu ee Crohn's la. When granuloma can be seen on the skin also, then it is called as metastatic Crohn's disease. Okay, it doesn't mean that it is the cancerous stage. Look here, guys, Crohn's disease, you can see skip lesions. You can see skip lesions. Okay, these parts, these are normal areas. Fine. Now, ulcerative colitis. Okay, let's move on to ulcerative colitis. So, ulcerative colitis, again, it comes under inflammatory bowel disease. Again, there is immune pathology, autoimmune pathology, where there is mucosal inflammation of the colon. Okay, and here the rectum is involved. We Crohn's il padichu. Crohn's though doesn't like rectum. Rectum is spared. Ivide it involves the rectum. Okay. Now, see, look here, guys. In ulcerative colitis, there is continuous involvement of the intestine. നമ്മൾ ക്രോൺസിൽ എന്താ പഠിച്ചത്? സ്കിപ്പ് ലീഷൻസ് ആണ്. ഒരു ഭാഗത്ത് ഇൻഫ്ലമേഷൻ ഒക്കെ ഉണ്ടാവും, അതിനുശേഷം കുറച്ച് നോർമൽ ഏരിയാസ്, പിന്നെ ഇൻഫ്ലമേഷൻ, സ്കിപ്പ് ഏരിയാസ് ഉണ്ട്, സ്കിപ്പ് ലീഷൻസ് ആണ്. പക്ഷേ ഇവിടെ ulcerative colitis there is continuous involvement of the intestine. And it often starts from the rectum. Rectathil ninnu start cheyyunnathu. Ulcerative colitis la inflammation evidana start cheyyunnathu from the rectum and then it moves upwards. Okay. There is retrograde involvement. This is what I said. The inflammation starts from the rectum, okay, and the inflammation is moving upwards. Adineyana nammal retrograde involvement ennu paraya. And there is backwash ileitis. And artham endha? See here, okay. The inflammation progresses and it reaches the ileocecal valve, and sometimes the colonic contents can enter the ileum and cause what? Ileitis. Okay, so that's why it's called as backwash ileitis. Ivide ulcerative colitis you get to see superficial ulcers. So you can see superficial ulcers and pseudo polyps. See, when there are superficial ulcers, okay, the nearby mucosa will try to regenerate. ഇവിടെ ഇപ്പോൾ ഇൻഡസ്റ്റൈൻ ഞാൻ വരച്ചേക്കുന്നു വെച്ചോ, സൂപ്പർഫിഷ്യൽ അൾസേഴ്സ് ഉണ്ടാവുന്നു ബിക്കോസ് ഓഫ് ഓൾ ദി ഇമ്മ്യൂൺ പാത്തോളജി ഹാപ്പനിങ് ഇൻ ദി ഇൻഡസ്റ്റൈൻ. അപ്പോൾ നിയർ അൾസറിൻ്റെ അടുത്തുള്ള intestinal cells, what do? They will try to regenerate as a compensation. Okay? So, but actually they are not polyps. They are not polyps. They are just trying to make up for what is lost. അതുകൊണ്ടാണ് pseudo polyps എന്ന് പറയുക. Pseudo polyps due to regenerating mucosa. And in ulcerative colitis, what you get to see is a lead pipe appearance on this study. See, here, you know that these pouches are hostrations in the area. Okay, these pouches. But in your condition, there is loss of hostra. Okay, and because of that, the intestine looks like a lead pipe. See, intestine looks like a lead pipe. So that's what you see here. In the barium study, you see a lead pipe appearance in ulcerative colitis. Now, ulcerative colitis, it is P-ANCA positive. We learned that before. One of the complications on a toxic megacolon. See, toxic megacolon means it is a dilatation of the colon, but there is systemic infection also. It's a medical emergency. Now, രണ്ടിലും Crohn's ലാണെങ്കിലും ulcerative colitis ലാണെങ്കിലും there is risk of cancer. Okay. And see, this is interesting. Smoking is protective in ulcerative colitis. നമ്മളത് പഠിച്ചിട്ടുണ്ട്. I am sure you guys would have learned it. But have you thought why? Why would smoking, which is actually very bad for the body, why is it protective? You know, nicotine, first thing, it reduces the inflammation. For smoking, these people will feel what? They'll feel better. So, it reduces inflammation. Second thing, nicotine, it increases the mucus production. നമ്മുടെ intestine mucus production കൂട്ടുന്നു. So, you know, this mucus will form a protective layer over the intestine and it can subside the symptoms for some time. So the patient feels better after smoking. So these are some theories on why smoking is protective for ulcerative colitis. What is the treatment for ulcerative colitis? We give aminosalicylic acid and mercaptopurine. Okay. See guys, as I mentioned before, we used to study that P-ANCA positivity is only seen in ulcerative colitis. New studies have shown that it is seen in about Crohn's disease, 11% ആൾക്കാരിൽ they show P-ANCA positivity. Okay, അപ്പോൾ അത് P-ANCA exclusively for ulcerative colitis ആണ് നമുക്കിപ്പോൾ പറയാൻ പറ്റത്തില്ല. Crohn's disease, if you want to diagnose, which antibody will you check? ASCA. Okay, this has come. All these questions have come. One-liners. Markers of intestinal inflammation, we have CRP. And in the stool, okay, intestinal inflammation ullappo, these markers will be elevated. Fecal lactoferrin and fecal calprotectin. They have come before, so just go through it. Alright, so now we are back to the first slide. I'm sure now this is very easy for you. We've read the question once. Just look at the picture and tell me what is your diagnosis. Look at the picture, you see cobblestone appearance, and this is a case. It is a case of Crohn's disease, right? So which is a specific feature related to Crohn's disease. Presence of polyps? No. We see that in ulcerative colitis. Limited to mucosa? No, that is also in UC. Superficial ulcers? No, that is also in UC. Transmural involvement. All the layers of the intestine are involved, are getting inflamed. So that is a feature of Crohn's disease. Alright, very simple, right? Ulcerative colitis always involves which part of the intestine, guys? It is rectum. Which layer of the bowel wall is typically affected in ulcerative colitis? It is mucosa and the submucosa. Ella layers illa, just the mucosa and the submucosa. Which of the following is not a feature of ulcerative colitis? See, continuous lesions, sheriyana. Skip lesions evideya കാണുന്നത്? Skip lesions we see in Crohn's disease. Okay. Most common symptom of ulcerative colitis is this they have asked before. It's bloody diarrhea. Which extra-intestinal manifestation is associated with ulcerative colitis? It is PSC, primary sclerosing cholangitis. The hallmark feature of malabsorption is, we just learned it, that was the first slide, steatorrhea. Whipple's disease is caused by, see, Tropharema whipplei. Pathogenesis of Whipplei's disease involves PAS positive, important, there's a PYQ, PAS positive forming macrophages in lamina propria. Initial treatment of Whipple's disease includes, it is, answer is C. ceftriaxone or penicillin G for 2 to 4 weeks. What about maintenance therapy? Answer is B. Okay. The main trigger for celiac disease is what, guys? Gluten. The harmful component of gluten is gliadin. The most sensitive antibody for celiac disease is anti-TTG antibody. Most specific is anti-endomysial antibody. Dermatitis herpetiformis in celiac disease is associated with which antibody? IgA. IgA. Duodenal biopsy in celiac disease shows all except. See guys, PAS positive macrophages in Whipple's disease, right? Celiac disease there is villus atrophy, crypt hyperplasia and lymphocytes. Tropical sprue is commonly seen in tropical countries. A. Deficiency occurring earliest in tropical sprue, this I have not discussed, it is folate. Okay? Earliest deficiency to occur in tropical sprue is folate. Crohn's disease mostly affects terminal ileum. Terminal ileum. Which of the following is not a feature of Crohn's disease? Skip lesions, creeping fat, continuous involvement of the colon, is it? No. Crohn's disease, skip lesions. Continuous involvement of the colon is in ulcerative colitis. String sign is seen in Crohn's disease. Ulcerative colitis invariably involves. Ulcerative colitis, it starts from where? Rectum, right? Characteristic endoscopic finding in ulcerative colitis is pseudopolyps. Lead pipe appearance of the colon is because of loss of haustra. Both Crohn's and ulcerative colitis increases the risk of colorectal carcinoma. Crohn's and ulcerative colitis, long term, they have this chance of getting colorectal carcinoma. Okay, find out the statements that are true about Whipple's disease. It is caused by Trophorema whipplei. Okay, that is correct. PAS positive forming macrophages. Well, that is also correct. Third, the disease is associated with anti-endomysial antibodies. No. So, 3 is wrong. 4, initial treatment includes ceftriaxone or penicillin G. Yes, that is also correct. Okay. Anti-endomysial antibody, where do we see, guys? In celiac disease. So, answer is 1, 2 and 4. In 1, 2 and 4, that is the answer. Okay. This option is wrong. Find out the statements that are true about celiac disease. Harmful component is gliadin. Well, that is true. Okay. Second, the most sensitive test is anti-TTG antibody. Okay, that is true. Duodenal biopsy shows villus atrophy and crypt hyperplasia. Yes. Rectum is invariably involved. Did I say that? No. So, actually 4 is not the, that's not correct. 1, 2 and 3. That is the answer. Find out the statements that are not true about Crohn's disease. Now, the not true whether Crohn's disease, transmural inflammation and skip lesions, very true. Rectum is invariably involved in Crohn's disease, is it? No. Crohn's disease, rectum is spared. We just learned that, right? Cobblestone appearance and creeping fat, yes. Crohn's non-caseating granulomas, yeah, that also we see. So, 2 is wrong, okay. Assertion. In celiac disease, anti-TTG antibody is considered the most sensitive test. Tissue transglutaminase modifies gliadin, which triggers an abnormal immune response. Actually, both A and R, random shariyana, and R is the correct explanation for A. Ulcerative colitis typically shows continuous involvement of the colon with rectal involvement. Crohn's disease is characterized by skip lesions and rectal sparing. Both are true. Random shariyana. Okay. So, we have come to the end of the class. I hope you guys understood. And in the first session, I went a little deep into the the way things happen. But in coming sessions, I don't know if we have time to cover it well in this detail. But let's try to make it fun. Let's try to make learning worth reading, right? So I'll see you all in the next class. Take care.